Hi, my name is John Lee from Artisan Lab USA. In today's video, we're going to review what we need before the surgery day and on the surgery day, and also when the implants are healed for full arch cases. We need mainly the patient's photo first, the CT scans, and the patient's complaints, things patient wants to improve. And also, we need to have a plan before the surgery day. We need to know how many implants we'll be putting in, and also how much bone reduction needs to be done. We need to check the transition line, and we need to have overall teeth setup. Just like before with the analog workflow, we used to do teeth setup before the surgery, but now the teeth setup is done on the digital space. The patient's CT scan, face photo, and the intraoral scans. To make sure the data is correct, if the patient was moving during the CT scan, then we see something called double image. Basically, we're seeing multiple images instead of just one. It's basically a blurry photo. So we need a clear data, and also we have to make sure that even the intraoral scan is not distorted. And for that, there are some tips to it, such as starting from the middle area and then going to the patient's right side and coming back to the middle and then going to the patient's left side of the arch. But now the scanners became a lot better compared to before. So if you just use a good scanner like Shining 3D, then you don't have to use any of these tricks. You can just scan and you will know that the data is good. On the surgery day, we normally take a scan, check the records again, if the records are matching compared to what's actually inside the patient's mouth. And if the patient is biting in the same position every time, or if they're biting differently every time. Because if you have a bad record, we have the record or scan of patient biting differently from the normal position, then most likely when we make temporary teeth, it'll be off position. There are a few different workflows, but the most popular workflow now is checking the records we have are same inside the patient's mouth and putting in the fiduciary marker and doing the scan with the marker prior to extraction or before the surgery, so that we can use that fiduciary marker to come back to the original data, mainly for the bite. Sometimes we don't have to do any extraction, so that extraction time will be saved. But if we have to do more complicated extraction and bone reduction, then that will take more time. On the surgery day, it depends on the doctor's preference, but a lot of doctors will prefer to have someone from the lab come out on the surgery day and take care of conversion process, because surgery alone is a lot of work. But if doctor is confident, or let's say especially younger generation doctor, I noticed they tend to buy more newer technologies like newer scanners, newer 3D printers for their new office. And if they have those, then they can just work together with a lab remotely, and the lab can just do the planning together remotely with a doctor over a Zoom meeting. And on the surgery day, we can have a chat, and also by calls we can design and we can assist. We can even remote onto their laptop or computer connected to their scanner, so we can see where they're scanning, what kind of data they're getting. If they're scanning the right area, we can assist them remotely and also design a prosthesis, and they can 3D print on site. With the impressions, it took longer, and also it was harder because some data needs to be scanned instead of taking impression. Only difficult part of scanning was before the scanners were very slow, but now the scanners are fast enough that you don't want to take an impression. Let's say if it's first time, then the doctor will be pressured not only for the surgical part, but also restorative part and also the workflow, because now the lab is usually involved unless a clinic has in-house lab. So the coordination, the planning, making sure everyone's doing for the full arch, everyone involved needs to be on the same page and know what they're doing. And they need to know exactly what's going to happen. So I feel like at least if one person knows exactly what needs to happen in each stage, then it will help a lot. If the patient is traveling for the surgery, then we'd like to convert the surgery, then we'd like to convert on the same day. But if it's same day, we have some challenges, such as we have to wait when we're making the teeth. So if it's the next day option, then patient can go rest and they don't have to wait during the fabrication process. That just depends on the preference from doctors and patients. We mainly bring our scanner, photogrammetry scanner, intraoral scanner, the fiduciary marker, the scan bodies, and the obtrugate, and anything that can be useful for the surgery. We used to bring an immediate denture before the surgery. It's basically a pre-made denture before the extraction. But nowadays we can actually make those dentures on the surgery day using the 3D printers. 3D printers are generally faster. It takes 15 minutes, sometimes 10 minutes for 3D printing. The milling machine alone, the cost is a lot higher, on the $50,000 range, and also heavier too. We're talking about at least 200 pounds or higher. And you have to think about a lot of different parts, such as air compressor, water, air, and the tools. But with the 3D printer, there are not many moving parts. With the milling machine, there are 5 different axes. But 3D printing, the cost is lower, it's faster, it's a lot simpler to use. 3D printer and the resins are still getting better. Every year there are new resins getting stronger. A few years ago, I would say the 3D printed temporaries weren't strong enough. But now a lot of people are using 3D printed, they feel like it's good enough. Successful conversion, it depends on accurate data. And photogrammetry became popular and became a hot topic because now with photogrammetry, you don't have to think too much about who's taking the record. Yeah, it just became a lot easier. But now with the photogrammetry tool, we can think about other things, such as, is the implant moving? Is the MUA moving? Is everything tightened? Is the bone solid or mushy? Yeah, those are the things we can focus on more. But let's say if you're not using photogrammetry data, then we have to make sure the principle stays the same. Have to have a good hand or a good assistant or a good person when someone's scanning without using photogrammetry technology. There's a higher chance of distortion if the person doesn't know how to take more accurate records without using photogrammetry. Recently, I'm bringing photogrammetry scanner as well as the intraoral scanner. It's a 2-in-1 scanner from Shining 3D. And I'm normally using my phone to take photos. There are a lot of things you can do, but the main strength of exocad is that it does really well when you're aligning multiple scan data together. There are mainly 2 options. The first one is automated alignment, and second is manual alignment, but this matching result with 2 scans. In exocad, what we're usually doing is we're matching 2 scan data together, but we usually have, let's say, 5 different scans per arch. And we have to make sure all these scan data are matching well. we can manually match and also verify if it's going to have a good result or not using numbers, using cut view, and also some other tricks in ExoCAD. Using older workflows, we cannot backtrack the result. Let's say we're setting up the teeth with wax and denture teeth, then there's no way to backtrack it unless we make a model, we stone model, we just have that physical stuff. But with the digital newer workflow, you can always backtrack what the result was bad, what happened. We can always backtrack and see what was the problem. And we can plan everything before the surgery day so that everything goes smoothly. The new workflow using the new technologies didn't come out of nowhere. Those were all built on the previous workflows, like the analog workflows. We're just making it better by using new tools and technologies. So the fitting is better compared to before. The aesthetic is better. We can plan everything before the surgery and share that and communicate with surgeon and the restorative doctor before the surgery, because before it was hard to communicate, but now we have many tools, not only group message, Zoom meetings, online meetings, so everyone is on the same page, the implant positions, the teeth positions. Yeah, a lot of questions will be answered before the surgery so that we're not guessing anything. One of the patient I remember is patient in mid-40s, and patient looked sad, not confident at all before the surgery, and didn't want to smile at all. But after the surgery, the patient he was actually a lot taller than me. And before the surgery, he looked shorter too. But after the surgery, he was smiling more, talking more, and also feeling more confident. And we're talking about what kind of foods he's going to be eating and what he's going to be doing that evening, or possibly going on a date. Yeah, overall, he looked a lot younger and healthier, so I was very happy with that. We are always learning, but I would say we're one of the very first. We're doing great communication. We're making sure we have a plan before the surgery day. A lot of experience working on these cases. At this moment, we have a surgery we have to start right now. We feel confident, we know what to do, and we know how to make it work. I would say if the clinic is already used to some type of workflow, then telling us, hey, I'm using this workflow, do you know this workflow? That'll be good enough. And I can make a recommendation if we should go with that workflow, or if we want to make any changes for any reason. Thank you for watching. I hope you found everything useful. Please don't forget to click like button and also follow us on social media. Looking forward to next time. Thank you.